at Ohio State University, earning Bachelor of Science in Physiology, and medical school at Ohio State University from 1966 to 1970. Where he developed an interest in primary and secondary prevention of atherothrombotic disease. Over the last 26 plus years, he has spent his professional life in medicine perfecting a tool to predict the population at risk of atherothrombotic disease. And to guide therapy to maximally stabilize, reverse that disease if extant. Thus, he has founded the Bowling Green Study of Primary and Secondary Prevention of Atherothrombotic Disease, BGS, to which he is principal investigator. This study terminated on 4th of November in 2003. Dr. Feeman has 6 major articles published in various science medical journals. He has had numerous letters to the editor published in various medical journals, all publications related to the primary and secondary prevention of atherothrombotic disease. He has presented data at a number of annual scientific assemblies of the American Academy of Family Physicians and at a number of national and international symposiums in atherothrombotic disease. Dr. Feeman is the founder of Association for the Prevention of Atherothrombotic Disease in Northwest Ohio to facilitate the spread of knowledge about this disease. The title of his talk today is Enhanced Prediction of the Population at Risk of Atherothrombotic Disease. Okay, Dr. Feeman, we are ready for you. Please start.
Thank you for your nice introduction. Just a little update. I am no longer at Wood County Hospital, and this work is based on 40 years, which is an update from the 26th. In any event, I would like to start with some general principles that everyone should know if they're interested in preventing atherothrombotic disease. Now, atherothrombotic disease, or ATD for short, is atherosclerosis with emphasis on the clot that so often produces the clinical events such as a heart attack or stroke. Now, in general, if you're going to predict, there's some things that you have to understand. First off, in order to predict the future, one must know the past. In other words, you have to understand the natural history of what you're dealing with. To predict the population at risk of ATD, one has to know the causes of ATD and how those causes interact to predict. William Connor said it best. He's an epidemiologist, was at Iowa, then moved out to Oregon, when he said, one does not treat blood components to achieve a certain goal. One treats to prevent disease. How do we know how to treat to prevent disease? Framingham told us 50 years ago. And there's some tenets that I'd like to share with you first. As William Cannell, MD, once said, atherothrombotic disease does not come as a bolt out of the blue. Rather, such conditions are due to, let me say that again. Such events are due to conditions originally known as factors of risk, but now called risk factors. Those risk factors are causal. They're not associated. They're causal. The Framingham study is defined. Sorry, I didn't get a whole lot of sleep last night. The Framingham study has defined those risk factors as cigarette smoking, dyslipidemia, hypertension, and some contribution from the very high levels of blood sugar and uncontrolled diabetes. The best marker, according to the Framingham study of dyslipidemia, is the ratio between total cholesterol and HDL. I know that's not the mantra that's out there, but that's what Framingham said. They were right 50 years ago. They are still right today. Framingham further says, in the absence of these risk factors, ATD does not occur, well, at least until very late in life. There are no ATD risk factors which are unique to the ATD population. Everybody has them. It's simply a matter of degree. Furthermore, and I think most importantly, given today's mantras, risk factors do not operate as independent risk factors. They operate as a continuum. one risk factor interacts with another to produce the AT events. They are not present, risk factors are not present in an all or none scenario. They are simply, as I say, a spectrum with a high risk end and a low risk end. The events in younger ages congregate at the high risk end. The events at the lower ages congregate at the low risk end. Less severe risk factors can cause atherothrombotic disease, ATD, but they do so later in life, unless there's a number of them interacting together. These are from Framingham. You can read the literature from 50 years ago, and you will see all these tenets deliberated. I would like to add some ideas of my own to that. It is always degree and duration of risk factor. You can have a really bad risk factor and you get your heart attack, stroke, or whatever at a younger age. You can have a lower intensity of risk factor and it happens at a lower age. The problem with now is that we put statistical analysis, and statistical analysis has to have independent risk factors. That gives you the most statistical power. However, one should understand that you should never sacrifice truth on the altar of statistics. Some people say, well, we can only go with randomized controlled clinical trials. Randomized controlled clinical trials are all selection biased. Therefore, they cannot be used for general population predictions. You should beware of those who only know what they read, those who only know randomized controlled clinical trials. Those who only know what they read may not have read far enough. The next suggestion I have is that one should begin testing for atherosclerotic risk factors early. One should repeat as appropriate, but if there's an abnormality, one should treat early and treat intensively. I think those are the reasonable things that you should do to try to, sorry, there's a green, let's see, remind me tomorrow. Okay, here we go. Now, in order to predict a population at risk of atherothrombotic disease, you have to know the risk factors of the patient. The risk factors were detailed by Framingham. So in order to know what Framingham knows, you need to have a database. I set about collecting my database in 1974. I finally terminated it in 2019 because by then we had 45 years of data, and I consider that to be enough. So entering all this data into a database, it was soon obvious, shortly after I began collecting the data, that you could separate out a population who developed atherothrombotic disease from those who did not. Why? Because back in the 70s, predictions for who was going to develop atherothrombotic disease or ATD were very poor. I mean, we had a rough idea, but nowhere near what we can do today. As a result, many of my patients did develop atherothrombotic events. As we got better at predicting, fewer people developed events. However, I live in a sea of pagans, in the original Roman sense of country folks who don't want to be told what to do. And so even though I predicted for them a heart attack or stroke, they went off on their own. But Bowling Green is a small town, and their fates became known to me. In any event, I was looking at the databases, and the first thing that I noted was risk factors hardly ever happen in a solo fashion. They're almost always in combination. Blood pressure was fairly simple. Cigarette smoking the paramount role of cigarette smoking became obvious to me in 1983 when I had enough people develop events and virtually all the younger folks were cigarette smokers. The cholesterol issue was a little bit less clear. You could see people with low levels of LDL cholesterol having heart attacks, people with high levels of LDL having heart attacks, people with high levels of HDL having heart attacks, people with low levels of HDL having heart attacks. In 1981, a paper was published, and I do regret not being able to give you the source on this, but they asked the question, is the LDL-HDL ratio the best lipid predictor? That's why I went back and looked at my database. And lo and behold, those people with high levels of HDL that had heart attacks had sky-high levels of LDL, or they were cigarette smokers in younger folks and hypertensive with or without diabetes patients in older folks. The same thing with LDL. People with low levels of LDL that had heart attacks or strokes had very, very low levels of HDL, or they were cigarette smokers, younger patients, or hypertensive patients in older patients. So it became apparent to me that it really was the ratio that made the difference in prediction of ATD. The next thing I did then was to look at combinations of risk factors to see which would predict, because remember that risk factors hardly ever acted alone. And I looked at every possible combination that I could, but the only ones predicted were the ratio between LDL and HDL and systolic blood pressure. And even then, you couldn't tell the relationships until you stratified by cigarette smoking. In 1983, it occurred to me that what I really wanted to know was the amount of cholesterol accumulating within the artery wall. And this I figured would be best defined as the amount of cholesterol going in, that's LDL, minus the amount of cholesterol being removed by reverse cholesterol transport, that's HDL. That's a percentage of what the cholesterol entering the artery wall, which is LDL. Thus was born the concept of the cholesterol retention fraction, which is better than the simple ratio by about a factor of 5%. Now, let me see if we can get to the graph. I do not see the graph. All right, so I'm going to ask you to, let's see if we go further down. No, the graph is not on the program. I actually did send to you a copy of the paper that I wrote. If you could find that and put that up on the screen, that would be helpful. In the interim, I want you to do a thought experiment, namely that put the cholesterol retention fraction on the ordinate of a graph, put the systolic blood pressure on the abscissa of the graph. Now,
I'm sorry, in the middle of your talk, can you tell me the title of your title of article so I can find
certainly.
it?
Yes, it's the Enhanced Prediction of the Population at Risk of Atherothrombotic Disease, back to Framingham.
Okay, I will find it right now.
Okay, so when you put it up on the screen, we can stop the thought experiment. In any event, you can draw a threshold line once, well, before, let me go back. If you plot everybody who had a heart attack, stroke, or aneurysm on this graph, it's a scattergram. It's just sort of like a globular cluster of stars. But once you get rid of the current cigarette smokers, it lines up very nicely as a mainstream of patients who have cholesterol retention fractions of 70% or higher, regardless of the blood pressure. There are a few outliers, sort of like raindrops coming down from a cloud over in the right lower corner of the graph. So therefore, a threshold line has to be a diagonal in order to not miss those people who have their events purely on the basis of blood pressure. Now, having said that, all my data is based on the precipitation method of HDL measurement. In 1999, the manufacturers of the autoanalyzers decided that they would switch over to the enzymatic method. Problem is they didn't tell anybody about it, they just did it. The second problem is that the results on HDL for measuring by the precipitation method are not the same as the results as measured by the enzymatic method. In fact, the enzymatic method gives a value that is on the order of 10 milligrams per DL, that's 0.25 millimoles per liter, higher than what the results you would have gotten from the precipitation method. Since we calculate the results, since we calculate LDL cholesterol on the basis of HDL, that means if you use the precipitation method, you get one value. Let's see. Can you scroll down to the figures and tables, please? Okay, yes, I'm sorry. Go back one page. There we are. Now, you see the graph at the bottom of the page? Can you go up just a little bit to see the graph? There we are. This is good. This is my thought experiment graph. In any event, as I say, this is using the precipitation method. But since the HDLs are higher on the enzymatic method, that means the calculated LDLs will be lower. So if you use the enzymatic method, can we go down to figure 2, I think? Yeah, no, can you go down a little further? Nope, okay, sorry, go back to figure 1, please. And a little higher. There we go. Now, if you're using the enzymatic method, you have to change. So the threshold line there is done on the basis of the fewest false negatives. In other words, if I told you that your cholesterol was wonderful, I didn't want you to have a heart attack. So if you use, that's for the enzymatic method. And if you use that's for the precipitation method. If you use the enzymatic method, you have to lower that down to a little bit. The enzymatic numbers would be a threshold line determined by .68 and 0.40. That way you can draw the threshold line that way. All right, now you can do a number of things with this. So let's come down to the figures 2, please. Yes, here we are. Now, this is for the male population. There's a similar figure for female populations. What I did was I plotted the number of people who transgressed the threshold line as they got older. The ages on the abscissa, the ordinate has the percentage of people transgressing the line. And as you can see, as people get older, more and more people have their plots above the threshold line. The red line is the percent of the population developing some atherothrombotic disease event. And as you can see, these lines run parallel. This is consistent with our thinking that there's an incubation period after which you get events. So the incubation period starts when you transgress the threshold line, and the red line then tells you when the events are due. Those are for males. If we could go down to figure 2B, please. These are the ones for females, and you can see they run parallel too. So the prediction in males is much the same as in females. Now let's go down to table 1. Keep going, please. Okay, we can, let's see, okay, let's go back up, please. Go back up a little more. Let's see if we can find the table. Okay, go up a little bit more. Yes. Now, here we have the results of what happens to people on this graph. If you're a cigarette smoker and your CRF-SBP plot is above the line, your average age of heart attack is 53. If you are and your average age of death is 65. sorry, is 59, beg your pardon. If, let's say, you're above the line, but you don't smoke cigarettes and you're a male, then your average age of event occurrence is 69. You don't die till 78. The numbers are virtually the same for females. If you're above the line and smoke cigarettes, your heart attack happens at 59. If you're above the line and don't smoke cigarettes, it's 73. But if you're below the line and you don't smoke cigarettes, it's 75. Males, as I said, it's 78. So this gives you outcomes of events. Now, that's one way to do it. There's another way to do it. Let's go down to the colored figures. That would be, keep going, please. Here we are. Now, what I did was I have 3,770 cholesterol retention fractions in my database. So what I looked at was what percentage, or what I did was, first off, is to put them into cohorts. In other words, let's say that you had a 80% cholesterol retention fraction and a blood pressure of 118, that puts you up in the left-hand corner. Or let's say you had a cholesterol retention fraction of 59% or less, and you're down in and a blood pressure of 180, you're down in the right-hand corner. But you can see the various cohorts. Then I put the incidence of ATD per cohort. In other words, in the left upper corner, there were 19 people who developed a problem in the study time frame out of 73. That makes 26%. They say, how can you have so few? Well, my answer is because I did not experiment on anybody. I offered people treatment. And so a number of people who might have developed an event didn't develop an event because they were treated. Now, the red, or it looks purple on the screen here, cohorts are those who have an incidence of atherothrombotic disease per cohort of at least 25%. In the yellow cohorts, they have between 15 and 24% incidence. And in the green cohorts, the incidence is less than 14%. What you see is a sunrise effect, a sunset effect, I should say, where the people with the lowest incidence of atherothrombotic disease are all sitting in the southwest corner. There is a sort of a twilight effect in the yellow squares, and then you get the major portion of disease. So this gives you an idea of what percentage of people and which cohort will get a problem. Can you go down to the next figure, please? Yes. Now, this is to show you the effect of cigarette smoking. It totally disrupts that nice orderly pattern that you saw before. And in fact, I say there's no place to hide, or very little place to hide, if you continue to smoke cigarettes. That's why you must quit smoking cigarettes. Let's go down to the next picture, please. This is for past smokers. You can see now we're beginning to get that organized picture again, where the southwest corner is the place to be, but there's still a legacy effect from cigarette smoking. In other words, you can't smoke for 30 years and quit and say, well, I'm back to square one. No, you're not. You have residual damage, which is why the past cigarettes still have a sort of scattergram effect. Now let's go down to the next figure, please. And here we see when you never smoke cigarettes. It's a nice organized effect. In fact, you can actually tolerate a reasonable amount of cholesterol if you don't smoke cigarettes. Now, eventually, the cholesterol will get you, but it's the interaction of all the risk factors, which I think you can see here. Now, let's go down to the next slide, please. And I think what I did on this table is to look at the incidence of the cholesterol retention fraction per age group in people who developed who, in the general population, who may or may not have developed some form of atherosclerosis. All right, let's go down to the next slide, please. Now, what you do is you do reverse Kaplan-Meijer curves. The reverse Kaplan-Meijer curves are simply the incidence of ATD per age group. And for your cholesterol retention fraction is 80% or more, you can see you have the uppermost line. In other words, you get into trouble at the soonest. If your cholesterol retention fraction is 0.75 to 0.79, then you're in the intermediate group. If it's 0.70 to 0.74, you're at the lower group. Let's go down to the next one, please. And here we are with the same figures when the cholesterol retention fraction in red is 0.65 to 69, in yellow 0.60 to 64, and less than 0.59. You can see that the ideal place to be is to have a cholesterol retention fraction of 0.59 or less. The incidence of atherothrombotic disease, ATD, in that population is very low. Now, it's not zero, but it is very low. So if we could go back up to the previous slide, please. Yes. Now, the idea is, let's say you have a cholesterol retention fraction of 80%. When do you want to start treatment? Well, it depends on the risk of ATD that you're willing to accept. If you say, I will not accept the risk above 15%, you've got to start in the 30s. See the age group on the bottom, the risk on the vertical line. Let's say you say, no, I'm a nihilist. I'm going to wait till you hit 25%. Well, then you got to start in the 40s, because if you go from the 25%, draw a line horizontally over and then drop down, you'll see that a 25% risk begins in the 40s. So that's when you'd have to treat. Thank you. Let's go down. The other thing, though, to say is that all the goals of treatment are based on hopping from one trajectory to another. In other words, you want to go from the red line in this slide, next slide, please, to the green line. And you can only do that by fixing the cholesterol. Now, the later you begin treatment, the further along the 80% Kaplan-Meijer curve you'll be, which means you probably won't get down to the green line. You may only get down to the red line. So that's the idea behind testing early and treating intensively. Now, let's go down to the next slide. This is the same sort of preparation that you saw earlier, but this now looks at the ATD population. This is all comers, and this is the average age of onset of ATD. And you can see that most of everybody who develops an event is sitting above 70%. There are not many, because this includes cigarette smokers, there are not many people who get their disease late in life, because some of those green slots are mainly never smokers, but there are some smokers in there, and ditto for the yellows. All right, so this is for all comers. Let's now look at the same slide. Next slide, please, for cigarette smokers. And you can see there ain't no hiding place for cigarette smokers. You're going to get the disease at a young age, no matter what. Let's go to ex-smokers. Yes, there we go. Now you can see that we're back up to looking like, as far as the average age of ATD onset for the all-comers. Most people who develop a disease who've quit do so with a cholesterol retention, quit smoking cigarettes, do so with a cholesterol retention fraction of 70% or higher. And there are a fair number of green cohorts, people who didn't get their disease until age 75 or higher. Let's go to the next one, please. And this is the one for never smokers. Virtually all the early age HED patients are above 75%. It shows you the critical role of cigarette smoking. We have a lot of yellow and a lot of green and not much red if you don't smoke cigarettes. So this represents 45 years worth of work in somebody who had instilled in him in a young age the idea of predicting who's going to have a heart attack or stroke. If you remember the basic tenets of the Framingham study, all this will make eminent sense to you. Now, the people who do the mantras will all tell you this has not been vetted against standardized populations. My next talk tomorrow will show you what happens if you don't use the cluster attention fraction, what happens in 8 published angiographic regression trials. Thank you very much.
Thank you, Dr. William.
Thank you, Dr. Feeman.